Guru, AI ultrasound-based formula. Aaron, please come up and tell us about your experience. And then if we have a few minutes to run slightly over time, we'll talk about intraoperative OCT.
Awesome, thank you, Dan. Appreciate the invitation. It's good to be here with all of you. I'm Aaron Waite, I'm in Utah, and I'm happy in this case to be an external validator of these techniques. I'll show you kind of what I've been doing. No financial interest here. Which button do I hit, by the way? Down, there we go, got it, okay. All right, good. So in the past, especially when I was using the Vision, and at the beginning of the EVO, I was using white to white, pretty much like most people would. That's what I was taught. And I've had the RTN now for the last couple of years, so I'll go through some of that. But initially, they were used white to white from orb scan transition to the Pentacam along with the AC depth. That's how we're trying to come up with this white to white. Of course, or the nomogram. They had to optimize it because they were too high with the first FDA approved numbers that they were putting out. All right, so as not to repeat, I'm gonna keep going. With this method, there will be outliers. There will always be outliers with this method. So if you're doing white to white, you will have outliers. If you haven't had outliers, it's okay, you just haven't done enough surgery. Does that make sense? That was the thought I had. I was wrong, I had outliers. Other people who have encountered this with white to white have had outliers and they realize that it's true. White to white, you have outliers. Okay, so in my case, what I ended up doing to try to minimize the risk was I did them on different days, kind of like Dr. Lin was saying. Just every case I did, the first eye, non-dominant eye, and then a couple days later, the next eye. And I used the day one post-op vault to kind of make me gauge, okay, how can I safely do this with using white to white, how can I do it as safely as possible? So my recommendation is if you are using white to white, don't do them both on the same day, okay? Separate them by a day or two, whatever it takes. All right. With this technique, my personal exchange rate was about 2%, which is in line with pretty much all the other data that's been presented using white to white. The good news is not all sizing misses need to be exchanged, especially now with the EVO. Okay, so a couple years ago, I got the ARC scan, and I started using that. The nice thing about it, honestly, it's easy to use. I train technicians. My technicians are with me usually for about a year before they go to medical school. So I have pre-med gap year students. We can train them within a week or two to do this scan. It's not hard, it's very straightforward. All right, the test is taken up, sitting up, so they don't have to lay down. You go to the machine and it's kind of like a goggle and it fills up with water. So it's weird, but it's easy to do. All right, the nice thing is with this device, currently with the software, ICL sizing is built in. So you can go in there and plug in the measurements and then it's already uploaded to the software and it turns out with the sizing. ICL Guru is now integrated, but it's not automated. So you have to go in there and upload everything to their website. It gives you great images like this. Dan's gone through very well on explaining what these different sizing methods are as the machine gets just great high quality images. Same thing he's talked about cysts already. You can't catch that within anything anterior. All right. Those can affect the sizing, obviously. So, for example, this is just one of the cases, you've seen this before, but this one kind of surprised me because it called for a 12.6 in the right eye and a 13.2 in the left eye, and I was like, this is crazy, there's no way. That's just weird. But this is stuff that you will encounter. One eye is different than the other. Of course, most patients you'll use the same size in both eyes, but that's just not always the case. And what's nice to see in this case, post-op OCT shows the ICL size was right on. This totally saved me from an exchange or a toric rotation, right? Okay, with ICL Guru, you get these images that are nice and helpful, and it will give you a toric rotation stability estimate as well. So in this case, a 13.2 will give a vault of somewhere around 300, but you've got a stable rotation with that size versus the 13.7. Okay, let me show you my data. So it's my own personal data. I'm gonna consider myself an external validator to this. I'm not developing the techniques. I'm the second guy who's like saying, hey, this works or this doesn't work, right? So if you look at my own personal data, this is before ICL Guru was integrated into the Insight. This is using ICL sizing with the ARC scan with the Insight 100. And you can see on this that it's actually relatively tight. So 250 to 750 is pretty darn good, about 83%. Over half are within 100. At the 300 mark, we're close to 90%. That's actually not too bad. That's pretty good data compared to other methods we've seen today. You can see that the outliers, there's 3 of them that are outside 500. The good news is With these numbers, we still didn't have to exchange any of these lenses, which is good to see. All right, and now we were able to get ICL Guru incorporated into using the Insight, and this is one cohort looking at ICL sizing versus ICL Guru. Now keep in mind, ICL Guru is awesome, but I'm not using the Sonomed, right? I'm using the Insight. Most of ICL Guru's efforts have been put into using the Sonomed to really optimize that nomogram, which does not equate to a different machine, which does not equate to the Insight. Okay, with this cohort, we got 77 within 250 to 750. The interesting thing is to look at the within 300, we're 86%. Now keep in mind, this is a different cohort than the first cohort, okay? But we're 86% within 300 with ICL sizing, 81% with the ICL Guru. Both are good. ICL sizing right now is actually optimized for the Insight. So in my numbers, it's actually been more accurate. Looking at this number, I'm not showing the ICL sizing, I'm just showing the ICL Guru. It's interesting to look at this chart. You can see that it's pretty much undercalling it every single time, more or less, right? So there's probably some improvements that can happen with ICL Guru over time, right? So both are excellent methods using this machine. In my cohort, ICL sizing was closer to target. Half the cohort presented earlier was from the older, was in that cohort with ICL sizing was using a different ICL sizing software because they had just updated. So the new one's actually a little bit more accurate. I anticipate that in the future, these nomograms will get better, ICL sizing will get better as they start to help with that nomogram, kind of like optimize that nomogram. All right, thank you.